The human heart contracts 100,000 times a day. To maintain that relentless rhythm, every cardiac muscle cell requires a massive, uninterrupted supply of energy. When this organ fails, it does not happen instantly. Heart failure is the macroscopic result of a highly predictable 10-step cellular cascade. The primary constraint of a healthy cardiomyocyte is its absolute dependence on continuous adenosine triphosphate, or ATP, to manage precise ion gradients. Without that molecular energy currency, the cell loses control of its electrical excitability. This diagram shows the cellular baseline of a healthy cardiomyocyte. Notice the tightly coordinated structures along the outer membrane and the internal sarcoplasmic reticulum, or SR, that govern electrical excitability and muscle contraction. During a normal heartbeat, electrical depolarization opens L-type calcium channels. A small amount of calcium enters the cell, triggering a massive release of calcium from the internal SR storage through the ryanodine receptors. This sudden flood of calcium forces the muscle to contract. To relax the muscle and reset for the next beat, the cell uses ATP to power the CIRCA pump. CIRCA actively transports calcium back into the internal sarcoplasmic reticulum. Simultaneously, the ATP-dependent sodium-potassium pump clears out excess sodium, restoring the resting membrane voltage. If this microscopic, highly energy-intensive cycle of calcium release and reuptake is disrupted at any point, the individual cells fail to synchronize. Macroscopic organ failure becomes inevitable. Moving to step 2, this section maps the diverse initial insults that assault a healthy cardiomyocyte. At the macroscopic level, common triggers are ischemia, reduced blood flow, or a chronic pressure and volume overload that physically strains the muscle. There are also microscopic triggers. A mutation in the TTN gene can weaken titin, the giant protein scaffold giving the sarcomere its spring. Alternatively, viral infections like Coxsackie B can directly invade and damage the myocytes. Regardless of the initial trigger, step 3 illustrates a common biochemical consequence, a catastrophic drop in ATP levels due to failing oxidative phosphorylation. Because the heart is always working, mitochondrial demand is exceptionally high. ATP starvation immediately strips the cell of the power required to execute a forceful contraction, sequester calcium, and maintain vital ion gradients. This energy deficit leads directly to step 4, pump failure. The sodium-potassium ATPase slows down, causing intracellular sodium to rise dangerously. In response, the sodium-calcium exchanger becomes far less effective, or can even reverse its flow. At this stage, the cell has not yet structurally collapsed. However, without sufficient ATP to run its pumps, the myocyte has completely lost control over its internal electrical environment. The direct consequence of a failing CIRCA pump is a lethal bottleneck. Calcium enters the cytosol during depolarization, but cannot be efficiently pumped back into the sarcoplasmic reticulum. A common misconception is that more calcium creates a stronger contraction. In reality, a higher volume of calcium does not mean a better pump. The heart requires precisely timed calcium cycling, not just a high quantity of it. This split-screen chart illustrates the difference. On the left, a healthy heart shows a clean, rhythmic sine wave of precise calcium release and rapid reuptake. On the right, an ATP-starved heart shows a jagged, elevated baseline, where cytosol calcium remains chaotic. This unsequestered chaotic calcium triggers erratic after depolarizations. These abnormal, spontaneous electrical discharges occur before the cell has fully reset, directly leading to life-threatening triggered arrhythmias. Beyond electrical instability, excess calcium causes immediate physical destruction. It activates intracellular proteases, enzymes that rapidly chew through the cell's own structural scaffolding. The mitochondria attempt to compensate by absorbing this excess cytosolic calcium. Overloaded, they suffer secondary injury, which severely worsens the initial ATP deficit. The very ion absolutely required to generate a heartbeat has now become the primary agent of the cell's physical digestion. As the mitochondria fail, the myocyte accumulates toxic metabolic exhaust, mapped in step 5. The damaged mitochondria generate high volumes of reactive oxygen species, specifically superoxide and hydroxyl radicals, which rapidly oxidize critical ion channels and damage the sarcolemma. This chemical equation highlights a particularly destructive interaction. When local superoxide molecules react with nitric oxide, a gas normally produced to relax blood vessels, they combine to form a highly toxic molecule called peroxynitrite. Because the nitric oxide is consumed to create peroxynitrate, the cardiovascular system is stripped of its primary mechanism for protective vasodilation, creating profound localized endothelial dysfunction. Returning to the main diagram, Step 6 shows a secondary metabolic crisis. Because oxidative phosphorylation has failed, the cell resorts to anaerobic glycolysis, quickly flooding the cytosol with lactate and hydrogen ions. This sharp drop in pH causes severe acidosis, directly reducing myofilament calcium sensitivity. It paralyzes the actin-myosin cross-bridge cycling and drastically reduces the physical force of contraction. At this exact point, the surviving myocyte is choking on its own metabolic exhaust, paralyzed by intracellular acid, and being structurally shredded by free radicals. Step 7 illustrates that the damage of individual cardiomyocytes does not happen in isolation. Injured cells broadcast heavy distress signals to the systemic immune system. The arrival of key cytokines accelerates the decline. TNF-alpha depresses contractility and promotes apoptosis, while interleukin-1 drives local inflammation. Simultaneously, TGF-beta activates cardiac fibroblasts, forcing the tissue to transition from flexible muscle into rigid collagen scar tissue. In viral myocarditis, infiltrating macrophages and lymphocytes arrive to clear the infection, but end up causing massive collateral damage to remaining healthy neighboring cells. The body mounts an aggressive immune response to clear out dead tissue, but that very response ultimately accelerates the physical destruction of the struggling muscle. Step 8 details the final compounding error: toxic systemic compensation. The brain and kidneys misinterpret the failing heart as a simple drop in blood pressure. The sympathetic nervous system floods beta-1 receptors with norepinephrine, artificially forcing increased heart rate and contractility. This creates a lethal paradox. Forcing a structurally damaged, severely ATP-starved cell to work even harder exponentially increases oxygen demand, rapidly accelerating complete tissue necrosis. The kidneys trigger a similar maladaptive cascade. Sensing low perfusion, they activate the RAS pathway. This hormone cascade releases renin to ultimately synthesize angiotensin II and aldosterone. Angiotensin II forces severe peripheral vasoconstriction, drastically increasing afterload. Meanwhile, aldosterone forces the body to retain water, driving up preload, the sheer volume of fluid stretching the weakened ventricle. The heart attempts to defend itself by releasing natriuretic peptides, like BNP, to offload this dangerous fluid volume. However, these signals are entirely overwhelmed by the massive systemic RAS cascade. These evolutionary mechanisms were designed to rescue systemic blood pressure during acute trauma, but with cardiomyocyte injury, they simply work the failing ventricle to death. Step 9 of the diagram maps exactly how this microscopic cascade of calcium chaos, protease activation, and toxic compensation physically reshapes the macroscopic organ into 4 distinct clinical phenotypes. The first pattern is dilated cardiomyopathy. The ventricle stretches into a large floppy sac, characterized by severe systolic failure and a critically low ejection fraction, meaning it can no longer pump a sufficient percentage of blood out of the chamber. The second pattern is hypertrophic cardiomyopathy. Here, the muscle walls become pathologically thick and stiff, creating severe impaired filling and massive diastolic dysfunction. The third pattern is restrictive cardiomyopathy. Severe stiffening of the cardiac tissue causes similar filling problems, though these patients often present with a preserved normal ejection fraction in the early stages of the disease. Finally, arrhythmogenic cardiomyopathy is characterized by the physical replacement of muscle with fibrofatty scar tissue. This occurs primarily in the right ventricle and leads to severe, prominent electrical instability. Regardless of the specific structural phenotype, Step 10 shows the ultimate binary outcome for the individual cardiomyocyte at the end of this long sequence. A moderate injury with some residual ATP forces the cell into apoptosis and slow fibrotic remodeling. Conversely, a severe acute injury strips the cell of all energy, leading directly to explosive cellular necrosis. A failing heart is not a single spontaneous event. Macroscopic organ failure is the inevitable physical manifestation of a microscopic collapse in cellular energy gradients.